see this or hear me? Does that look good? Okay,
Great.
so we'll just jump right in because feels like there could never be enough time. So I'm Dr. Alexis Ritvo. I'm co-chair of the Benzodiazepine Action Work Group with the Consortium, along with Dee Foster, who, if you all are able to attend the third session on benzo-induced neurologic dysfunction, you'll have the pleasure of meeting him. And I'm also an assistant professor of psychiatry with the Colorado School of Medicine and the addiction psychiatry program director. So I did an additional fellowship in addiction psychiatry. Because of my background in addiction, have an interest in withdrawal management and certainly even in general psychiatry, saw a lot of patients coming on chronic benzodiazepines and realizing that they had not been well informed about the risks of long-term use and some of the problems that can come with that. And then also we're having difficulty or being mismanaged and trying to help them get on less, if not completely off them. So that's a lot of what got me involved in this. And then I will let my better counterpart here, Dr. Gold, introduce himself and talk about where his interest came from.
Nice to meet everybody and good afternoon. My name is Jeff Gold, Dr. Gold, and I'm a psychiatric clinical pharmacy practitioner at the VA Medical Center. And essentially what that means is that I'm a prescribing psychopharmacologist. I finished my PharmD, and then for folks who go on to become psychopharmacologists, it's generally a 2-year residency in psychiatry. And then after you finish your residency, you do a year of practice where you're signed off by a psychiatrist to have a scope of practice with prescriptive authority, and then you go on to take an exam which is where the initials BCPP come from, Board Certified Psychiatric Pharmacotherapist. And so I work with veterans at the VA and prescribe medications. I do mental health assessments, and I got involved in benzodiazepines some years ago in partnering with Dr. Haug, James Haug, who's an addiction psychiatrist at the VA. And we started the benzodiazepine tapering clinic in roughly 2015, I believe. And after getting interested in benzodiazepines and working with a number of veterans who are coming off of benzodiazepines, I started to really investigate the history of benzodiazepines in more detail. And I always was just fascinated by the history of the medications that were invented in 1955, Librium chlordiazepoxide by La Roche Pharmaceuticals. And shortly thereafter, within several years, they had reformulated the benzodiazepine Librium into Valium. And very shortly thereafter, all the other drug companies at the time saw how successful these medications were and began to develop their own benzodiazepines. And by the 1970s, all the most frequently prescribed medication lists in the country were topped by benzodiazepines, 1, 2, 3, 4, all benzodiazepines. And it really wasn't until the 1980s that, one, we began to recognize the mechanism of benzodiazepines, and two, that there was the specter of abuse, dependence, tolerance, and potentially withdrawal when these medications were abruptly discontinued or used long-term. And it was really patients, not the medical community, that began to recognize these issues, which is, I think, pretty unique to the history of benzodiazepines as well. It's a pleasure to be here.
Thanks. And I'll just ask Dee and Susanna, I can't easily see the chat while also in presentation mode. So if you see any questions you think should not wait till the end, please let me know. I'm going to start off and then I will hand over remote control here. Oh, maybe I can see them. To Dr. Gold, and we'll hopefully go back and forth. So I think, I just want to start with giving just a little background further about why we're here and why we felt doing a 4-part series on benzodiazepines was so important. And you'll see both of these headlines come from 2018. So we're already almost 4 years ago. And some folks were trying to sound the alarms of benzodiazepines becoming our next prescription drug epidemic or other prescription drug epidemic following opioids. And the reason for this is we have only seen prescriptions go up. 2019, Agarwal published this study looking at ambulatory visits where benzodiazepines were prescribed and found that between 2003 and 2015, the percentage of outpatient visits where they were prescribed had doubled. So that's pretty striking. And not surprisingly, half of that is occurring in primary care. So actually they found in psychiatry, the rates had stayed about the same, and I believe they were about 30%. But in primary care, they'd gone up. And this is not to vilify primary care. I have huge respect for primary care and how much behavioral health primary care has to manage with short visits and limited specialty resources. And so I think it just speaks to how, how stressed the system is and limited on the ability to refer to other interventions that aren't as quick as signing a script, especially when these are medications that are well known by the public. And we know them to be in short term very effective, especially for what we see them most commonly prescribed for insomnia and anxiety. But as we'll go through in this talk, as we talk about some of the, what the indications are when we do use these, these have really only been approved to be used for 2 to 4 weeks in most cases. But the problem is once they're started, they're almost always continued. And this is in part because of the limitations on visits, right? You have a 15-minute visit, and then you might see someone back in 3 months, maybe, but probably in primary care, 6 to 12. And you can't constantly be dealing with phone calls about refills. In psychiatry, we have a little more flexibility in our clinical care model, and we tend to see people back usually, a month, 2 months, at most 3 months, but it still happens. So what this shows here is the rose is return visits, and the darker kind of crimson is new visits. So in each age group, and you see it creeps up with age, the majority of visits where a benzodiazepine is prescribed is a follow-up visit. And what that tells me is most likely in those 80 to 90% of follow-up visits where they're prescribed, it's being continued beyond a month. And so this is, I think, something that just further shows us we really need to do a better job of educating our patients about the long-term risks and really thinking about how and when, if we start these meds, we're going to manage them. So just to go over our overall objectives for today, we want to explain the neuropharmacology of benzodiazepines, describe appropriate indications and alternatives to prescription benzodiazepines, want to show you how to utilize the benzodiazepine action work group prescribing guidance document and informed consent document to more safely prescribe benzodiazepines, and help you understand the Colorado rules that were enacted based on House Bill 21-1276 that limit the initial supply of a benzodiazepine that may be prescribed to a patient who has not had a prescription for a benzodiazepine in the last 12 months. So with that said, I'm now going to attempt to get fancy and give Jeff remote control, if I can control my own screen, and let him kind of lead this next section.
Let's see if I can do it here. Let me see.
There we go. Sometimes you have to click twice.
Okay, it's right here.
There you go.
Let me back up here. And before we get started on this component of it, Dr. Ritvo and I took significant time thinking about how we would best outline this. And so the way this is broken down across our 3 presentations is starting with the pharmacology, then going into the appropriate usages of benzodiazepines, potential alternatives to benzodiazepines. And then in our second part, we review some of the safety issues, the acute and long-term safety issues of benzodiazepines. And finally, in our third session, we talk about the tapering process and withdrawal symptoms. But we're going to begin talking about the neuropharmacology of benzodiazepines. And we'll start by talking about the neurotransmitter GABA, or gamma aminobutyric acid. And this is the primary inhibitory neurotransmitter in the central nervous system of human beings. And glutamate is the primary excitatory neurotransmitter in the central nervous system. And we'll be talking about that as well. So essentially what happens is GABA binds to the postsynaptic GABA receptor on receiving neurons. And when GABA binds to the GABA receptor, specifically the GABA A receptor, the neuron then allows for the entry of chloride ions or anions into the postsynaptic neuron. And The accumulation of chloride ions in the postsynaptic neuron essentially makes that neuron not responsive to any sort of electrical excitation. And ultimately what this results in is a decrease in the ability of the neuron to be excited, to transmit a nerve impulse, and it essentially prevents the propagation of an action potential. Remember, that's like when the electrical signal causes the release of a neurotransmitter into a neighboring neuron. That creates an electrical sensation in that neighboring neuron. That neuron then releases its neurotransmitter, and there's a cascading effect, and that's essentially what the propagation is. And so when a benzodiazepine is administered, it enhances the activity of GABA, the inhibitory activity of GABA at GABA A receptors. And the benzodiazepines, interestingly enough, they bind to a site that's different from GABA itself, but they still potentiate the effect of GABA. And this is what is called an allosteric effect. And we'll show a video of that here in a moment. And benzodiazepines at the GABA A receptor enhance that inhibitory effect by allowing more chloride ions to enter the postsynaptic neuron. And so this, again, just further reduces the degree to which the nerve produces an electrical impulse, and it further increases the resistance to excitation. So again, it just enhances the inhibitory effect of GABA itself. Now, the GABA A receptor that binds to benzodiazepines has a specific name, and it's actually just called the benzodiazepine receptor. And there are different subtypes of the benzodiazepine receptor itself, and they have different properties. The alpha-1 subtype of the benzodiazepine receptor is thought to be responsible for a lot of the sedative, amnestic, ataxic effects of benzodiazepines. The alpha-2 subtype has more anxiolytic, relaxing properties. And then the alpha-1 and alpha-2 together both have an effect on the anticonvulsant properties of benzodiazepines. Now we're going to watch this short video here. It's about 2 minutes long. Let's see how this pulls up.
I think, let's see, does it work on mine? I might have to.
Yeah, you might have to do it.
Exit full screen here.
Perfect.
And then, actually, I think I had it up here. So give me a.
There we go.
Welcome to 2 Minute Neuroscience, where I explain neuroscience topics in 2 minutes or less. In this installment, I will discuss benzodiazepines. Benzodiazepines are a class of drugs named for their chemical structure that are commonly used to treat anxiety disorders and sleep-related disorders. They include well-known drugs like Valium, Xanax, and Klonopin. There are dozens of drugs in the benzodiazepine class, but the mechanism by which they all exert their effects is thought to be similar. The sedating and anxiety-reducing effects of benzodiazepines are believed to be attributable to the drug's actions at receptors for the neurotransmitter gamma-aminobutyric acid, or GABA. In particular, benzodiazepines act at a subtype of GABA receptors called the GABA A receptor. GABA A receptors that also bind benzodiazepines are sometimes called benzodiazepine receptors. When benzodiazepines bind or attach to the GABA receptor, they bind at a location separate from where GABA itself binds and exert an influence over GABA binding. This type of action is called an allosteric effect. In the case of benzodiazepines, it results in increased action at the GABA receptor. There's not complete consensus on exactly how benzodiazepine binding affects activity of the GABA receptor, but there's evidence to suggest that it increases the likelihood that GABA binding will activate the receptor and or increases the effect that GABA has when it binds to the receptor. That effect is to open an ion channel and allow the passage of negatively charged chloride ions into the neuron. This influx of negatively charged ions pushes the membrane potential further from zero, or hyperpolarizes it, and makes it less likely the neuron will fire an action potential. This type of neural inhibition is the basis for the effects of benzodiazepines, for by inhibiting the activity of neurons that make up networks involved with anxiety and arousal, the drugs are able to produce calming effects.
Okay.
Great.
So repetitive, but on purpose. I think I'm someone that's very visual and can find it really helpful to hear it again and actually see a picture of it. So let me see if I can get us back to where we were. And Jeff, are you able to take?
Yeah, let me see here. I think so.
Okay.
And this is just, we heard it, it was explained, we went through it in detail, then the video is a nice way of hearing it. And this is just one more graphical depiction of this mechanism. So again here, neuron 1 would be the presynaptic neuron, neuron 2 is the postsynaptic neuron, space in between being the synapse. And again, what happens is a nerve impulse causes the release of GABA into the synapse. GABA interacts with the GABA receptors on the postsynaptic neuron, causing chloride to enter the postsynaptic neuron, and that goes on to hyperpolarize the nerve and inhibits the outgoing nerve impulse. Benzodiazepines bind specifically to the GABA A receptor in a specific site on the GABA A receptor of the postsynaptic neuron, and then that boosts the actions of GABA and further enhances the inhibitory effect. 3 different ways, can never hear it enough, right? We also know that the different parts of the brain, of course, are responsible for different functions. And depending on where these nerve impulses are being inhibited, where benzodiazepines are working, we see specific changes or we see specific effects. Cerebral cortex, the administration of a benzodiazepine, that enhanced inhibitory effect, will decrease our ability to think, to concentrate, to use and access our working memory, to be aroused. In the cerebellum, a benzodiazepine can cause incoordination, a loss of balance. In the reticular formation, a decrease in arousal. In the hippocampus, it can further impair our memory, our working memory, our ability to focus and concentrate. In the limbic system, it can cause changes also to emotions and memory. And in the limbic system, as well as the amygdala, we also know that there's an effect of benzodiazepines on reward and pleasure. And this is complicated. There's a more complex mechanism by which, even though benzodiazepines are depressants ultimately, they still actually cause a release of dopamine in some circuits of the brain. And that's why they have some degree of producing euphoria and having reinforcing and rewarding properties, but ultimately themselves are still depressants. A few other sites that we're going to pay particular attention to are the amygdala, where fear circuits are. And we know that in the fear circuits, reducing that signaling can reduce the anxiety response. In the cerebral cortex, decreasing conductivity and decreasing that action potential and can, from one neuron to others, can reduce seizure conductance. In the spinal cord, we know this can produce reduced muscle contraction. So again, just remember that the location and activity of the binding subtype determines the therapeutic effects of benzodiazepines. Another important phenomena is something that is known as uncoupling, and specifically uncoupling of the GABA A receptors. And essentially what this refers to is that uncoupling decreases the ability of the benzodiazepine to potentiate GABA at the GABA A receptor, and it also decreases the ability of GABA to potentiate GABA A receptor binding. And ultimately, what we think of is that with repeated dosing, repeated administration of a benzodiazepine, your body becomes resistant to the effect of the benzodiazepine. This is part of the phenomena of tolerance, which we'll talk about in a moment. So that uncoupling of the receptor really may represent a compensatory mechanism to control GABAergic neurotransmission under conditions in which the receptors are being persistently activated by a benzodiazepine. And so when you think about tolerance, what's actually happening is that you ultimately see, with repeated administrations, a decrease in endogenous GABA and a downregulation of GABA A receptors, and just an overall cumulative decrease in inhibitory impulses throughout the brain. And then there's a compensatory increase in endogenous glutamate, and as well as norepinephrine and serotonin. And remember, when you think about this, really the function of glutamate is to increase the activity of serotonin, norepinephrine, and dopamine, while the activity of GABA is to inhibit or to reduce the activity of serotonin, norepinephrine, and dopamine. So, but ultimately with tolerance, you see a cumulative increase in excitatory impulses to counterbalance the constant and chronic introduction of a depressant into the central nervous system. Thus, when these medications are abruptly stopped or discontinued, you can get a runaway excitatory effect that can result in the withdrawal symptoms of benzodiazepines when they're stopped abruptly, and which can be fatal and result in a number of medical and psychiatric issues. This is an insidious process. This isn't always something that patients are aware is like happening to them. And the way that it may manifest is the original drug has progressively less effect with repetitive dosing, and the patient experiences less of a benefit from the medication over time. And tolerance to the various therapeutic effects of benzodiazepine varies by therapeutic effect. Generally, the sedative, hypnotic, and amnestic feeling that people most commonly associate with taking a benzodiazepine diminishes within 1 to 2 weeks. The anxiolytic effects, data really has shown or suggests that that might not last more than 4, 5, 6 months. The anticonvulsant effect diminishes over the course of weeks to months with chronic and consistent administration. However, and unfortunately, tolerance to the cognitive and the memory impairment effects of benzodiazepines does not seem to occur despite chronic use. And again, tolerance is really understood to be the result of neuroadaptations. That is, the neuroadaptations, which are changes to the GABA A receptor conformation, as well as the uncoupling from the GABA A receptor, as we talked about previously.
So I will add here, I mean, that picture there with the balance is probably one of the concepts I most try to impart upon my patients, both when they come to me having been on a benzodiazepine chronically and saying, you know, it's not working, or I'm no longer getting the effect I used to get, or if I see a patient self-increase the dose or has been increased over time by their previous prescriber, as well as explaining to patients if we do decide that it's warranted to use this in the short term, why I really want to try to avoid chronic use. Because our body's constantly trying, nervous system, to create this homeostasis and keep us, you know, adequately alert, awake, breathing, mentating. And so that's why we make these compensations, that if you're constantly exposing it to something sedating like a benzodiazepine, then underneath your nervous system's actually riling up with glutamate to try to keep this balance. And then if we take away that chronic sedation too quickly, you'll have that overactivation underneath. And hence also the importance of really making sure they understand, you know, if you've been taking this regularly and you cut back too quickly or you stop, you are at risk of not only uncomfortable withdrawal, but actually life-threatening withdrawal in the form of a withdrawal seizure. So the other thing to understand, while, you know, we're talking kind of generally about benzodiazepines, they are all slightly different, and we'll continue to talk about some of the differences. And, you know, if you look, now in hindsight, I'm like, oh, maybe we should have put up a picture of the molecular structures. But if you look at them, on the one hand, they have a lot of similarities with their benzene rings. And at the other hand, you'll see they have different, you know, attachments at the end that change some of how they work in the body, and also why there's some imperfect cross tolerance when switching from one to the other. So it's important to keep in mind they do vary by how potent they are and how they're eliminated in the body. Overall, in general, half-life is going to affect how long they're active, as well as the potential intensity of inner dose withdrawal that might develop. If it wears off more quickly, you're more likely to experience withdrawal symptoms between doses. Regardless of the half-life, the noticeable therapeutic effects, so often we're speaking about on anxiety and sleep, are only a few hours. And the majority of benzodiazepines are eliminated via hepatic metabolism. So of course, important to keep in mind when using in a patient that has any sort of compromise in their liver function, and excreted by the kidneys. And the exceptions being lorazepam, oxazepam, temazepam. I don't know about others, but LOT has always stuck in my mind from, you know, the days of step one. And benzodiazepines with active metabolites, which is usually the longer acting ones, those metabolites accumulate once you have those repeated daily dosing. So most often seen with the long acting ones, diazepam, chlordiazepoxide, and clorazepate. Clonazepam also has some active metabolite, but not quite as long acting. Want to call particular attention to alprazolam and clonazepam. So I'd say those, along with lorazepam, probably the ones we see most frequently prescribed on a kind of ambulatory basis. And alprazolam and clonazepam are probably our two most potent benzodiazepines. They're the most rapidly and efficiently absorbed, so they have a more rapid onset. They also have a higher affinity for the GABA A receptor, and that is associated with their greater potency. And one of the ways, you know, you can tell about the potency is look at the doses. So, you know, alprazolam 0.25, clonazepam 0.25 is equivalent to diazepam 5 milligrams. So, you know, you're getting these much smaller initial doses that they come in. And it's actually because of that potency, as well as the shorter half-life of alprazolam, that these are two that I generally actually try to avoid using, because I find they tend to be ones that become harder to get individuals to taper down off of because of their potency and the limitations in dosing regimens. We'll talk about that more in detail when we talk about tapering. And with alprazolam, between this combination of how quickly it onsets and offsets and the risk of interdose withdrawal, and this high affinity, it is just extremely reinforcing. And actually, when they've done studies and looked at the dopamine response people get, alprazolam is far and away the most rewarding because of that short on, short off phenomenon.
I want to jump in too, because this is data from 2020, and when Dr. Ritvo presented this to me, for many years in the benzodiazepine tapering clinic, and even when I was teaching residents at the School of Medicine, the Department of Psychiatry, clonazepam was often thought to be one of the better benzodiazepines because it was longer acting. And it was one we would often use to taper people off of, that or diazepam, sometimes chlordiazepoxide, sometimes clorazepate. And when this data came out, it really changed the way that I practiced, mostly due to the thought that the hallmark of a drug with mind-altering properties and potentially addictive properties is a fast onset of action. And really the goal of using these medicines, particularly in a tapering process, is to not alter the mind, but is to not cause precipitous changes, but to help cultivate other ways of thinking about coping with anxiety and distress and finding ways to calm one's mind to sleep. And so this certainly is relatively newer. And when I was introduced to this data, it changed the way that I thought about not just a long-acting agent, of course, but just how quickly an agent onsets its activity.
Yeah, thank you, Jeff. And another property that has to do with how quickly something will onset is how lipophilic it is. So midazolam, which of course we see a lot with used in anesthesia for sedation, and then also longer acting diazepam and chlordiazepoxide are more lipophilic and therefore cross that blood-brain barrier more quickly. So you do get some more of that quick onset that can actually be very useful, especially in the setting of acute withdrawal from benzos or from alcohol, to try to stabilize things, but then to also get that much longer acting and active metabolite, so you don't get it wearing off and getting interdose withdrawal. So thinking about, when you think about duration of action, you actually want to be thinking, are you acutely administering something versus is someone taking something on a regular repeated basis? So if you're acutely administering it, you're most affected by the lipophilicity and the volume of distribution of the drug. If you're chronically administering it, then the individual is going to be most affected by how quickly the drug is, its elimination half-life, as well as if there are active metabolites. So I think that's an important thing also to keep in mind when we're thinking about using something truly as needed versus something that becomes that they're taking on a regular scheduled basis. And then this is just, you'll see this again and again, I think we kind of combine two versions of equivalency tables. I think a big thing to call attention to is, there are dose ranges, there's imperfect cross tolerance because of different people having different metabolisms and especially different cytochrome P450. They might be a slower, quick metabolizer for certain of those proteins. It may affect what the equivalency is for them. So especially I see this with clonazepam and when trying to switch one to diazepam. So just, I think the lesson you'll hear again and again is, when all fails, go slow and make small changes. And I think that goes both when starting and when tapering folks off.
And certainly when you're converting from one benzodiazepine to another, like opioids, there is some cross tolerance. And sometimes if you give somebody an equivalent dose of an opioid, it's often too much. And when converting somebody from, let's say they're taking 2 short-acting benzodiazepines and you're going to say convert them to diazepam to begin the taper, you might make a small dosage reduction at the time that you convert them, just to account for some of the potential cross tolerance that Alexis was referring to.
So next we'll launch into talking about appropriate indications and alternatives to prescription benzodiazepines. And Jeff, I think you
Absolutely.
start with that.
There are a number of places, there are a number of indications for benzodiazepines where they may be used for first-line treatments or the standard of care. First and foremost, for alcohol withdrawal and for benzodiazepine withdrawal. Of course, in an inpatient hospital setting for acute alcohol intoxication, you're using a CWA protocol or a SOS protocol to help get somebody safely get them off of the withdrawal from alcohol to prevent any sort of bad outcomes such as a seizure or anything else. The same is true for tapering people off of benzodiazepines. The same risks are also present, and it's standard of care to use a benzodiazepine to help safely get somebody off of benzodiazepines. Also, for a status epilepticus and an acute seizure, benzodiazepines are often given as an injectable to abort a seizure. In crisis anxiety without psychotic features, benzodiazepines can be used. I think this is one of the more difficult first-line indications to characterize or to wrap one's mind around, because generally we're trying to avoid the use of benzodiazepines for anxiety. They're not considered first line. But in a setting where the anxiety is, let's say, functionally limiting somebody, their ability to participate in life is so impaired and they're under acute stress to the extent that they're not able to manage, then in those settings, a short-term, several-day course of a benzodiazepine with clear instructions can be very useful. Another common indication for benzodiazepines is for procedure anesthesia. We see this all the time when people have received fentanyl and midazolam together for anesthesia, or they receive twilight sedation, which is commonly oxycodone with lorazepam. Some unique conditions such as burning mouth syndrome, which is a pain disorder. There's some data for using clonazepam first line. We know for a number of acute movement disorders that benzodiazepines are first line, such as stiff person syndrome, catatonia, and status dystonicus. In catatonia, we see this on an inpatient psychiatric setting where, and some of those individuals are managed with benzodiazepines long-term, or else they may fall back into some degree of catatonia or a complete catatonia. And finally, in end-of-life and palliative care, we might use benzos just when kind of gauging quality of life and functional capacity of somebody, just to make their final time here more comfortable to them. As far as second-line use of benzodiazepines, these are the indications where it gets a little bit more controversial and a little bit more difficult to gauge and assess. So we're going to dive into these in a lot more detail, starting with insomnia. We're going to talk about anxiety disorders as well, which is defined as lasting longer than 6 months, that are functionally limiting, and the anxiety is greater than the perceived threat and the symptoms are severe in nature. And finally, certain treatment-resistant intractable seizure disorders, they may try to use benzodiazepines long-term. And I can tell you that I know from talking to some of my colleagues in neurology, as well as Dr. Bainbridge, and wrote the DePiro chapter on epilepsy, that oftentimes they really try to limit the use of benzodiazepines as a long-term treatment in epilepsy. And the reason is they want to preserve abortive treatments if they're needed. They'll try to maintain folks on anti-epileptic drugs whenever possible, and save the lorazepams and the other agents that they would need to use acutely to abort a seizure. But in some circumstances, in some treatment refractory cases, they may consider using long-term chronic benzodiazepines. One of the general principles with benzodiazepines is to always use the lowest effective dose for the shortest duration possible, to not destine somebody to a lifetime of taking these medications if you're going to use them. And as Alexis stated earlier, the data really is only for 2 to 4 weeks, and for most of these indications, particularly anxiety and insomnia. Some of the places where you might see them used, and this might be thoughtfully done to help improve the quality of life of your patients, is in prolonged sleeplessness, and you might use the benzodiazepines for 1 to 3 days, maybe sometimes 7 days. It depends on the individual, but this would be sleep problems not due to circadian rhythm or chronic sleep issues, but this would be more recent grief, acute stress, somebody was diagnosed with a life-altering medical condition, severe jet lag. These are all reasonable indications for a benzodiazepine. Also for severe and acute anxiety, if there's nothing else that is available to the patient at that time. And this might also be in a time setting when you're arranging other treatments, such as you've connected them to a therapist, or you've connected them to cognitive behavioral therapy for insomnia, or let's say you started a sedating antidepressant to treat anxiety, but it's really before that medication has begun to work. And through a discussion with the patient, you have really both come to understand that something is needed now. Many people can wait, or many people can practice other coping strategies or skills or other techniques, but in the event that they cannot, and their quality of life is being significantly hindered, they're not able to participate in life in a meaningful way, or they're finding themselves having problems in relationships or at work, using a short-term benzodiazepine may be needed or quite helpful to somebody at that time. And finally, for severe and acute muscle spasms, you'll sometimes see benzodiazepines used second line. As far as the efficacy of benzodiazepines, again, their efficacy data is really not great, is really looking at a 2 to 4 week time period. And for anxiety disorders, they're superior to placebo in reducing short-term anxiety, but less than 2/3 of patients experience a full remission of symptoms with benzodiazepines. And the anxiety often returns upon treatment discontinuation. And over time, and within several months, they often become tolerant to the medicine. So what this often looks like is that the benzodiazepines don't necessarily help my anxiety, but if I don't take the benzodiazepine, I feel much, much worse. With insomnia, in the short term, about 50% of patients experience some degree of relief, but again, tolerance to the sedative, hypnotic, amnestic effects generally occurs within the first few weeks, so the benefit is quite short-lived. And additionally, benzodiazepines appear to reduce the time spent in stage 3 and 4 sleep, as well as REM sleep. So it's thought that even though people might be sleeping, they're not achieving, or they're not getting the same benefits from sleep when taking a benzodiazepine. They're not getting that deep restorative sleep where we synthesize proteins and consolidate memories, so that we might get the benefits we get from sleep may be reduced from taking benzodiazepines. Some of the alternative treatments for anxiety disorders, Dr. Ritvo, Alexis will talk about this in a moment, include for social phobia, behavioral therapies. As far as pharmacotherapy for social phobia, SSRIs are second-line treatments, and panic disorder, the first-line treatments are SSRIs and SNRIs, as well as various forms of psychotherapy. For generalized anxiety disorder, SSRIs are first-line treatments, as well as various forms of psychotherapy. And really, there's limited evidence to suggest that benzodiazepines are useful once some of the first and second-line treatments for the myriad of anxiety disorders have failed. It's not a magic bullet waiting in the wings, that they're just actually not as effective. And when they are effective, sometimes their benefits are more short-lived as tolerance develops. And again, if benzodiazepines are to be used for this, for these indications, you really want to do it at the lowest dose for the shortest time period possible.
So when thinking about anxiety, and we'll also cover this for insomnia, really want to think about how can we connect individuals with our psychotherapies, which have good data and certainly a far better benefit to risk ratio. Cognitive behavioral therapy is certainly associated with large effect sizes and overall smaller rates of patient attrition or dropout compared to drug therapy or combined drug and psychological therapy. Certainly what I tell patients is if they're presenting to me with moderate to severe anxiety or insomnia, my recommendation is that meds alone are going to be insufficient. Usually mild, can do one or the other, though I recommend therapy first, but if available, because of the overall side effect profile being lower. But that if we're not doing both, then we're probably not providing adequate treatment. And then other exposure therapy, especially in things like panic and also obsessive compulsive disorder, and then a type of exposure in PTSD, and also things like anxiety management training. And then alternative treatments specifically for post-traumatic stress disorder. So first line is actually our serotonergic agents, so sertraline, fluoxetine, venlafaxine. For nightmares, we use prazosin a lot, but more recent evidence says maybe that it's not as effective as we once thought. And there's strong recommendations when you look at the VA Department of Defense guideline for PTSD against using benzodiazepines, antipsychotics, and divalproex. And the psychotherapies are really the gold standard in PTSD. And that includes cognitive processing therapy, prolonged exposure therapy, and EMDR, or eye movement desensitization and reprocessing therapy.
I might also add here too that we at the VA, there's some data as well suggesting that maybe when people are taking benzodiazepines, that they do not get the same benefit from the evidence-based psychotherapies. That cognitive processing therapy, even the word processing is in it, sometimes when people are taking benzodiazepines, their ability to process things are impaired. And I know at the PTSD residential program at the VA, they even did some small internal studies looking at when veterans would take benzodiazepines prior to going into therapy, and then they would really engage them around what are you getting from the therapy, or what are you trying to get away from the therapy if you're using, let's say, a lorazepam before you go into prolonged exposure or a CPT session. And that really that some of the core symptoms of PTSD, numbing and avoidance, that's the very mechanism of what benzodiazepines do. And so there's some thinking and some data to support that there's a diminished benefit from evidence-based psychotherapy in patients using benzodiazepines.
Yeah, and I'd also add, I mean, if you also think about that it's having some effect on sleep and the restorative parts of sleep that help with our consolidation of memory and learning, you're also going to further likely decrease the ability for you to gain as much out of these therapies. So Dr.
Yes.
Gold, do you want to talk about the medications for insomnia?
Yeah, as far as insomnia medications, I think that a few things, there's a lot important to say here, and I think this could even be a bigger conversation, but medications for chronic insomnia should be considered mainly for patients who cannot participate in cognitive behavioral therapy, where significant sleep hygiene has been reviewed and education has been reviewed and been practiced. And these patients should still have symptoms despite participation in treatments. And again, looking really at sleep hygiene and sleep-related behaviors. And in select cases, you might consider using a medication with CBTI. And something I talk to the psychiatry residents about when I'm teaching at the School of Medicine or School of Pharmacy is that if you look at the data, the first episode of insomnia that a patient experiences, if you are to give them a medication, it should really only be for 7 to 14 days tops. And that should really be done in conjunction with sleep hygiene, sleep education, and really putting that into practice. You shouldn't be destining somebody to a lifetime of sleeping medication, even if it's a trazodone or a doxepin or a melatonin. It should really be about resetting your sleep cycle and practicing developing good sleeping habits. And upon recurrence of insomnia, you might consider doing that again, another 14-day course or 7-day course as you practice these good habits and get back into a routine. You're really not looking to give somebody a 30-day supply of medication with 3 refills until they've developed chronic primary insomnia, multiple recurrent episodes of insomnia that reappear upon discontinuation of treatment or therapy. If you are to use medications, some of the other alternatives to benzodiazepines are sedating antidepressants such as doxepin, generally at 3 to 6 milligrams, sometimes even as low as 1 or 2. Even 10 milligrams is common, or even 20 milligrams. It's really not till you get to 20, 50 milligrams of doxepin that you start seeing some of those anticholinergic, serotonergic properties that are characteristic of a tricyclic antidepressant. Trazodone, at doses 150, 200 milligrams or less, even 300 or less, it's still primarily a selective H1 receptor antagonist and antihistamine. Other antihistaminic agents you might consider are hydroxyzine and diphenhydramine. Both are quite potent. Sometimes diphenhydramine is even more potent than you'd like it to be because it also hits the muscarinic receptors and sedating through not just being an antihistamine, but an anticholinergic. And finally, you have melatonin, valerian root, a number of other nutraceuticals, as well as prescription melatonin, which comes in the form of Ramelpion. So there are many other options that I'd say Benadryl comes with some risk. Long-term use of anticholinergics, we now know, has some of the same risks as benzodiazepines, but generally there's not tolerance in the same way where you're seeing conformational changes in the brain that can result in life-threatening withdrawal reactions that characterize the benzodiazepines.
Yeah, and actually just kind of commenting on that before going to this next slide, I just say, so these two references, one is from the American Academy of Sleep Medicine and the other from the VA, their insomnia guidelines, which are pretty recent and I think worth looking at. I believe at least the American Academy one says, benzodiazepines could be used. We would like to argue that their risks outweigh the potential benefits with these other options. I will say rereading them or looking at these newer guidelines, I was struck that I was like, oh, maybe I need to be using doxepin more. And they actually, we use trazodone, which I think a lot of people do. And that maybe didn't have as good of evidence as even the low dose doxepin. Melatonin didn't have great evidence, but its overall risk is low. The main thing I see is that patients tend to, if 1 milligram is good, then 10 is better. And instead trying to explain to them that if we're actually trying to mimic the physiologic effect of melatonin, you want to use a lower dose, like closer 1 to 3 milligrams, probably not more than 5, taken an hour before you go to sleep so that you can have that drop in the melatonin that kind of mimics what happens naturally. And then once you start using higher doses, you're more just getting some sedating effect from it, but also more likely to get some side effects. So I think those are, all things to keep in mind. And then again, both of these guidelines really emphasized all patients with chronic insomnia should receive cognitive behavioral therapy for insomnia as the primary intervention. So the evidence for it is so strong, and of course the risk for it much more pretty negligible, that it really should be offered to everyone. And that in short-term results, it was similar to medications, but actually long-term are improved. And I think that's because the focus of CBTI is it takes both the sleep hygiene, which we know alone just telling patients what they should be doing when they go to bed is not enough. I think most of us can agree if it worked for someone, including our primary care, just to say you should be working out, then we'd all be in awesome shape. But we also need to help them work on how do we recondition your brain to associate being in bed with going to sleep rather than being in bed with being anxious about not being able to sleep. And so really, I think learning, and would encourage everyone, a good use of your CME would be to learn more about how to educate patients about CBTI. And it's the sleep hygiene, but plus this idea of how do you use sleep restriction to help kind of reset people's conditioning so that they associate being in bed with being asleep, and that their sleep efficiency, the amount of time that they spend in bed, the majority of it's spent asleep. So 2 resources I like to refer patients to that are free, that have good information. Of course, this requires patients have some technology and a decent amount of health literacy, but that I'll even help patients download this on their phone and pull it up with them. I have the CBTI coach, which comes from the VA, completely free on my phone. They can keep a sleep log. It goes through the psychoeducation about it. So that's one. Sleepwell is from Canada. They also have a lot of good CBTI information, as well as some education about why sleeping pills are not as recommended. I would, as far as for places for CBTI, that's going to be probably specific to the place you're practicing in. I know for us, I'm within the kind of UC Health system, so we get referrals from UC Health to psychiatry. That's our referral source, and our group has a CBT insomnia group, and encourage folks to consider, if you have integrated behavioral health or that you do consulting with, seeing if they can provide a CBTI group or individual sessions. And certainly, see if a care coordinator can work with identifying maybe some psychology groups that do it. You could try looking on Psychology Today. At least people choose to put themselves on there as providers and do list what insurance they take. So I think those would all be good places to start. I'm not aware yet of a specific list that's just for CBTI. So in finishing up, just kind of want to take the last few minutes just to kind of review some resources available to everyone for free to help you more safely prescribe benzodiazepines. So through the Benzodiazepine Action Work Group, we created a prescribing guidance document and then also linked to informed consent that some of our other participating group members that are part of these other associations created. So you would go to our work group page, and here under projects, you'll see it should be updated soon to actually say guidance, because it's actually not a guideline, because it's not evident, we have not studied it and we're not saying this is the absolute, but it's what we would encourage folks to provide patients. But this is what it looks like, an overall guidance giving, I think it's about 2 pages plus references, just reviewing again, like here are the overall approaches you should take when thinking about prescribing benzodiazepines, remembering what primary indications are, second line, as well as potential contraindications. And then also remembering this really is a medication where, given its risks, especially with long-term use, that we should be doing a pretty concerted effort at an informed consent, ideally a written one, but at least making sure we verbally are going over this and get understanding. And so a reminder, informed consent is the process by which a healthcare provider discloses appropriate information to a competent patient so they can make a voluntary choice to accept or refuse treatment. And we must include describing reasonable alternatives to that intervention, the risks, benefits, and uncertainties of the alternatives, the nature of in this case, the medication, assessing the patient's understanding of these risks and benefits, and that they accept going forward with that. And the other thing is that, we have to remember, we're supposed to be assessing, is how we're going to prescribe this reasonable, and what a typical physician would both tell a patient about this intervention and do when enacting this intervention. What would we think most patients need to know to be informed about making the decision to start this medication? And is there something particular that this patient would need to know how this medication might affect them? So this is an informed consent that the Benzodiazepine Information Coalition and the Alliance for Benzodiazepine Best Practices put together. It is available completely for free. You can get to it, actually a link to it from our work group page, as well as by going to this website, and then from there can download a version, copy it. We only ask that you make sure to give, to note that it was created by these groups. So if you have questions about that, let me know. We'll take questions. I'll just get through this one last thing. So House Bill 21-1276, we were able to get an addition of a limitation on the initial supply of a benzo. And the idea behind this was what's one way we can help ensure that if patients are put on a benzodiazepine, that we're putting some limitations to keep them from falling into that 80 to 90% of patients that are getting it continued beyond a month. And so how it reads, so there's the law, and then that was created into a rule by DORA. So a prescriber must limit the supply of a benzodiazepine to 30 days, which is not very well defined, but just you get the idea. We're trying to keep it below beyond 4 weeks, including refills if a patient has not been prescribed a benzodiazepine in the past 12 months. The way the law read at the time was that prior to a second fill of the benzodiazepine, the prescriber must check the prescription drug monitor. I'm waiting on confirmation about whether subsequent changes to the PDMP made it so that now it's even on the first fill, which was actually what we had originally hoped for. So if anyone here knows, please put it in the chat. And then added that requirement, which this would meet some of, 4 hours of credit hours that medical providers must take prior to renewing their medical license. And that not only could that include information about prescribing opiates and managing pain, but also best practices for prescribing benzodiazepines. And this does include the few limitations or things that you could prescribe more than 30 days if it was for a patient with epilepsy, a seizure disorder, spasticity, alcohol withdrawal, or a neurologic condition such as, actually, we don't often, we'll tell you next time, use it in brain injury, but catatonia. So not trying to keep it from folks. And I guess I didn't include the point that was in the law itself. Is the whole point of this is to help decrease the likelihood someone started and then put on chronically a benzo, but also makes very clear we do not want people to rapidly tapered or stopped from benzodiazepines, and that's in no way the intention of this law. So now I know we just have a few minutes, but happy to take questions and stick around for questions. I encourage anyone that's interested in this area to join us at the work group. We meet every Tuesday, first of the month. We didn't today because of this. Virtually, you can go to the main work group page and sign up, or just to be on the email list. So in my view, I see Dr. Clapp with a question.
Hi, thanks for that. And your advocacy at the Capitol too has been huge. So I got my stuff on House Bill 1276, and so you did too. It was a great bill, so thank you for that. But one of the things I want to ask about, so I do inpatient pain and addiction, and so a lot of times you get patients that come in on methadone or chronic opiates, anxiety issues, trying to wean them off benzos, and when you're trying to kind of deconstruct these. So the only two kind of short-acting anxiolytics that I could find, because we don't really have the luxury of waiting for the time with the SSRIs or the SNRIs to kick in, but I use hydroxyzine and buspirone, and I've actually gotten some good effects with both, even though I know buspirone is supposed to take a few weeks to take effect. But I was just wondering if you can comment on that, or had any other suggestions on managing patients that come in that are chronically on both those issues, but are having acute issues and need something done quickly for them.
Dr. Gold, previously you did a lot of inpatient work, so certainly,
Yeah.
I
mean, I know that there are a number of things for anxiety that I've seen done or have done myself, or know to be done routinely to treat anxiety, and some of them are controversial in their own right, but I think hydroxyzine and buspirone are both great options. And even though buspirone has indications to treat depression and anxiety and is thought to have some of those more downstream effects, there's certainly like an acute effect from taking buspirone that I have found very helpful, and I know patients have found very helpful, and I think that's quite common. I've also seen for some individuals, again, when they can tolerate this, like the use of propranolol for anxiety. I've seen less routinely the use of prazosin. I work with a veteran population, so sometimes the sympatholytics are more commonly used. I've also seen, and I'm familiar with some data using gabapentin, but I know that there's some controversy surrounding that as well, since there's some potential for abuse and developing some degree of dependence with gabapentin. But I've seen that used for a number of folks quite well, and where they've had decent effect from it as well. Clonidine, again, another sympatholytic. I'm not a big fan of, just due to the potential for, if people take it routinely and then abruptly stop, you can also find yourself in like a medically complicated situation with rebound hypertension. So I think those are all good options. And I do in my practice actually use some gabapentin for those individuals as well, and have had pretty good effect with it.
Yeah, I'd also say, given how many of these patients do have concurrent trauma, and we have evidence for it in alcohol use disorder, at least one decent study. And so I've had some of those patients do well with low dose prazosin a few times a day. Yeah.
There's some data for that too, like using prazosin during the day, even for, there's a question here that I wanted to answer because I was almost going to bring this up before. And I'll come back to the mirtazapine Belsomra question, but there's a question from Nicole Amberson about withdrawal from antidepressants. And I think this is very important, because when benzodiazepines were discovered to produce a withdrawal reaction in the 1970s into the 1980s, and then legislators and clinicians started to develop guidelines around how benzodiazepines should be restricted, how they should become controlled substances, how guidelines should account for the adverse reactions to benzodiazepines, tolerance, withdrawal, etc. That changed the way the medications are fundamentally viewed and prescribed. And then the drug companies developed antidepressants. They started to reformulate antidepressants and developed SSRIs and SNRIs, which replaced the previously not as well tolerated TCAs and MAOIs. And when they discovered really that these antidepressants also could produce a withdrawal reaction when they were discontinued, the drug companies, in a bit of wrangling, sought to change the definition or change the terminology, and they didn't want to use the term withdrawal syndrome. They wanted to use the term discontinuation reaction. But make no mistake about it, if you don't, people can withdraw from antidepressants and have antidepressant withdrawal. It's not the same as benzodiazepine withdrawal, but it is very real, and anybody on an antidepressant for a substantial amount of time should also be tapered. Those withdrawal symptoms, can vary by agent, but look a lot like the flu.
Yeah, and I'll say, I mean, again, it comes down to, risk benefit. I think for a lot of people, the benefit of being on these agents, if they have extremely distressing, dysfunctional, for instance, like a generalized anxiety or panic disorder, that benefit outweighs the risk of potential withdrawal effects for many, not for everyone. Everyone's physiology is different, but I think the importance is that all informed consent makes sure patients know not to stop these abruptly, that they should always be tapered slowly, because we don't have a good sense of what makes certain people exquisitely sensitive. The biggest thing we know is probably with all these meds, there's some kindling that the more often you stop too quickly or decrease too quickly, the more likely you are to have onset of severe withdrawal effects. But I also, I see the whole gamut from people that I'm surprised a med that majority of people causes withdrawal or discontinuation effects, and they can stop with no problem, at least the first time. So again, it's just very individual. As far as
the worst outcome, I think well said, Alexis. Like, you think to prevent the worst outcome, I taper everybody. I talk them into a taper, lest they have, you can't anticipate who's going to have withdrawals or not. Same, I think that's why we have standards of practice and guidelines. Like, if somebody has a heart attack, how many, we suggest that they are on a statin thereafter. And of course, like, I'm sure that not everybody who doesn't start a statin or is not adherent to a statin would have a heart attack. But again, you're treating to prevent the worst outcome. And I often use that example when I'm talking some people into tapering when they just don't want to do it. And
So I see a question about mirtazapine and the orexin meds. Mirtazapine is good. At the low doses, you're mostly getting the sedating effect and not the other antidepressant effects. And then as you get higher, you're not getting as much, like the sedation doesn't get necessarily subsequently higher, but you start to get the serotonin, norepinephrine effects. So you just want to make sure you're not using someone where antidepressant would be contraindicated, or for instance, bipolar, and they don't have a mood stabilizer on board. Balsamra, there's actually, I think, is a super interesting med. It is a controlled substance. There's, like any of our centrally acting meds, some people are going to try to take more than is prescribed to see what effect it has. I have not been as concerned, at least thus far, with people misusing it. And there's actually, in the addiction research world, increasing research looking at what effects it has in the setting of substance use disorders, which is pretty interesting. So, if I'm at the point of thinking I need to try something that is a controlled substance, I'm personally going to try that if insurance will cover it before an Ambien, before a Z drug or a benzo.
About those drugs, I think mirtazapine is great. I use mirtazapine like for insomnia at like a 7.5 to 15 milligram dose. Like, the depression dose is really about at like 30 or so. As far as Balsamra, I've only used it a handful of times. I don't think I have the knowledge. I don't think I have the knowledge based upon practice experience to say like what are the concerns with it being a controlled substance and how that can look. But as far as I'm concerned, in the data that I've seen, that it does not have the same concerns surrounding it that a benzodiazepine would. And there's another medication question, and they can answer very briefly before tackling the cannabis question. But that is, how do you feel about the difference between doxalamine for insomnia versus diphenhydramine? I don't think about these medications as being terribly different. I think these are first generation antihistamines that have are not just antihistaminic, but are anticholinergic. They hit the muscarinic 1 and 3 receptors. Sometimes that can actually add to the sedation produced by the medication, but also some of the cognitive symptoms as well, like cognitive blunting or feeling hungover the next day. Sometimes I think that people respond better to them for that reason, but I also try to avoid using the first generation antihistamines, diphenhydramine and doxalamine, for sleep. If I can use something like trazodone or mirtazapine or low-dose doxepin or hydroxyzine. And the reason for that is really that those medications are more selective H1 receptor antagonists. They have the sedating effects of an antihistamine, but they don't produce all the anticholinergic effects that can, result in other side effects being dried out, and also some of the cognitive side effects of taking an anticholinergic. I just wanted, Gilda, did you have your hand raised, or did you get your question answered? Go ahead.
Couple of things. Yeah, I asked the Rexin question, but I use Prazosin for flashbacks during the daytime. I learned how to do that at the VA. It's great. Clonidine, same thing. You can use Lyrica and gabapentin for generalized anxiety disorder. And I love using propranolol because it's not addictive. My question is actually about dementia. What do you do if someone who has dementia, you can't do CBTI with them really? Do you have any recommendations on dementia-related agitation as well as dementia-related insomnia?
Well, I'll let Alexis chime in as he would, but I always think about some of the standard that I go to and I think about is the KDAD trial and managing dementia-related behavioral disturbances. And really, I think the data there shows, and like the SSRIs, citalopram, well, first off, that the behavioral interventions, the antecedents, the behaviors, the reminders in the room, that first off, there's all the non-pharmacologic components that are essential to managing somebody who slips in and out of lucidity. But as far as medications go, per the KDAD trial, I believe citalopram had some of the best data for treating Alzheimer's disease related dementia and behavioral disturbances. And then the other options are, not routinely done, and this is certainly not my area of expertise, but sometimes using low dose as needed or thoughtfully administered atypical antipsychotics, like for specific behaviors that are, problematic. I have also seen some of the geriatric psychiatrists use prazosin during the day, kind of controlling people's sympathetic response to stress. Like if somebody's slipping in and out of lucidity, and in a moment that they're not lucid, they become very agitated and irritable, and then they slip back into a moment where they might have more clarity in their thoughts. It could be very distressing to be in an environment that is completely unfamiliar to you. So for that reason, people can then become distressed, and there could be a cascade of norepinephrine, and they can essentially have an adrenaline response to their environment. And for that reason, I've seen some pretty good data and for prazosin being used in those individuals.
And those are also long-term benefit risk. If they get good effect from low dose benzodiazepine, this is nearing the probably palliative end of the spectrum. I think the bigger concern becomes as brains become more impaired, that you can have that paradoxical reaction where, they get more of a rebound, or they become more agitated or impulsive. So I think other things, of course, the atypicals have the black box warning and the use in elders, but again, long-term risk benefit, I think like all things, just whatever you do low, always better to go lower dose, and only make one change at a time when possible, and also really focusing on environment and behavior.
Thank you.
Yeah, pleasure. And then THC for sleep. THC, of course, can be its own lecture series. To me, there's so much variability depending, are we talking THC, what potency, what formulation, CBD versus THC. So, is it better than a long-term benzodiazepine for some people if they don't have a substance use disorder? It may be, but my concern becomes, and what I not infrequently see, is folks that start out and they also build a tolerance and becomes more and more. And if they have other things like anxiety going on, it can snowball. So certainly I don't think there's yet good convincing evidence, but also there's also a lot of issues with, getting proper studies of THC, but Jeff may know even more.
I think that, I do a lot of my work has been with THC over the years. And I think that the data is pretty clear that THC is not good for one's mental health. And if you look at the studies for PTSD, it's actually detrimental. Your likelihood of developing depression in the same year where you meet criteria for cannabis dependence, your risk for developing depression goes up fourfold. I could point to a number of
Anxiety
different
works.
like a number of different studies where THC worsens outcomes in depression, PTSD, schizophrenia. It really is not good for your mental health. Now, CBD, cannabidiol, there is some actually promising data, and really CBD opposes the actions of THC. So, and I think also, just even practically speaking, that there's a similarity of THC to benzodiazepines, and it's that there's a temporary escape and anesthetization of your emotions and feelings. And for most of the patients I work with, I'm thinking that I want to get them closer to being able to sit with the pain and discomfort and the hard things about living. And the goal is to decrease the need or the want to use a chemical to avoid and numb painful feelings. It's to get them to sit with those feelings more readily and more easily over time. And I think that cannabis does the same thing. It can kind of numb people and doesn't necessarily take them the direction of that the evidence-based psychotherapies would have them go. So for many reasons, I think that THC is not a good option.
Great. And I saw a question about, is there informed consent, or does the consortium have one for antidepressants? I don't think any of the work groups have made that a specific, area or topic that they're focusing on. Certainly, I think we have ones for opioids. I think really any medication a patient's going to take regularly, that they will develop some physiologic dependence on, especially anything that's acts on the nervous system. We should be doing an informed consent. I would imagine if you look, you can find some, but the consortium itself has not made one. So, well, thank you all, and thank you for staying past time. And so next week we'll be talking more about some of the risk contraindications with ongoing use of benzodiazepines in special populations. The third week about benzodiazepine-induced neurologic dysfunction, and then finally about tapering and deprescribing. So hopefully you can join. If not, they'll be recorded, and then our hope is that long-term we'll do a professional recording that we can then also list for CME, since the recording of this unfortunately does not qualify for CME initially. So,
thank you so much all for attending. It was a pleasure.
Bye.